Obviously, big topic. I'm very lucky. A lot of smart people are following me after my initial 10 minutes to kind of go in more detail. But I'm going to give you just a quick run view, anatomy, some biomechanical thoughts, and obviously healing of the rotator cuff. We're looking at the anatomy. Let's jump right into it. Four main muscles. Subscapularis is the largest of the muscles, has its own insertion site onto lesser tuberosity, and has the main function of internal rotation, which we talked a little bit about earlier. The supraspinatus, which is most commonly torn and probably the biggest bugaboo for our rotator cuff pathology patients, has an insertion onto the anterior and lateral portion of the greater tuberosity. Main function is abduction. You can see here with the arrow pointing to the supraspinatus tendon and a long head biceps tendon closely associated with this. The two posterior rotator cuff muscles, the infraspinatus and teres minor, they originate from the infraspinatus fossa and back at the scapula and insert onto the greater tuberosity. Their main function is external rotation. The anatomic footprint you're going to hear a lot about probably in the next hour because this aids in our diagnosis of our tears as well as repairing the tears, kind of looking at tear patterns. Subscapularis, it's on its own, has the largest footprint onto lesser tuberosity, and the infraspinatus has the second largest. And some of the newer morphology studies and anatomy studies show how this infraspinatus tendon posteriorly comes around, and you can see from this anatomy picture here, its fibers then insert and overlap on the top portion of the supraspinatus, so the ISP being infraspinatus. So it's a larger, has a larger emphasis during repair than initially thought. Anatomic footprint, this is getting into some of the deeper biology, but really four zones: the tendinous zone, the fibrocartilaginous zone, which is not calcified, and then there's a calcified fibrocartilaginous zone, and then bone. And these are important when we're thinking about the healing properties. And so we're, again, adding things like biologics and augmentation, we're trying to reproduce this anatomic footprint. The biomechanics, you think about the rotator cuff, and we talked about this a little bit earlier. It actively compresses the humeral head into the glenoid cavity. There's short lever arms. It's a pulley system, a very functional high machine that we have for our shoulder. This establishes this stable and dynamic fulcrum, the golf ball and the golf tee. You can imagine if one of these lever arms was torn or weakened, the whole machine would be shaking and not doing very well. This is something I was interested in. I learned a lot about when I was in Europe, this critical shoulder angle, and this is just to show some of our morphology and sometimes things that we're actually born with, maybe introduce some of this pathology. So this is at a Gerber's group in Switzerland. There's three groups: a control group with normal rotator cuff and no arthritis. Group 2 was a MRI documented full thickness rotator cuff tear, and group 3 were patients with no rotator cuff disease, however primary OA. They looked at this critical shoulder angle, which is this angle here with the purple lines that shows a vertical line matching the glenoid face out to the lateral edge of the acromion. And when they looked at kind of the averages of this angle, the control group was 33 degrees. The rotator cuff group that had full thickness tears was much higher, and the OA group was much lower. And you may think, okay, what does this mean? I think what it shows is there's definitely some biomechanics playing a part in some of our degenerative changes that we're seeing in some of our injuries. And so if you look at this in more detail, this picture on the left is the rotator cuff 38-degree group, and that was on average. The right shoulder is the DJD arthritis group with the lower angle of 28 degrees. And the main force vector of this is our deltoid. With the larger angle, the force vector is more superior. And so you're compressing the rotator cuff. The rotator cuff is getting worked a little bit harder with this angle. Whereas with the shorter angle, the smaller angle of 28 degrees, the force vector is more medialized, which is probably compressing our joint surfaces, adding to a little bit of arthritis. So things to think about, something I look at when I'm looking at x-rays of my patients may play a part when we're looking at healing of even partial rotator cuff tears. If they have a higher angle, may put them to a little bit higher risk of further progression of that tear. So rotator cuff healing, this is a huge issue. We'll touch briefly on it. Dr. Schlegel's going to go into more detail about techniques of the repair, but that's a widely variable thing with all surgeons. Patient factors need to come into play, including comorbidities and their compliance following surgery. There's implants and techniques, and then the biology, which is a huge topic, including stem cells, PRP, graft augmentation. But we'll touch a little bit on this. When we think about tendon healing, I think about four things. think about the biology, how we're going to kind of reproduce that anatomic footprint and make it look like those 4 zones, make it look a little more like normal tendon. The technical side of it from a surgical factor. There's environmental and patient factors that play a part in this, and then rehab, which Ellen's going to talk about to us later, and I'll touch briefly on here. So these associated factors, even with COVID and N95 masks, you can still smoke, unfortunately, and that's a very bad problem when we're trying to get tendon to bone healing. The vascular supply is limited. You got to think about age, and you got to look at the size of the tear, diabetes, and quality of the tissue. A lot of associated factors. We're looking at healing of a rotator cuff that can be involved. Just a little shout out to the Inverness site, but we'll talk a little bit about rehab. Delayed versus early rehab has been looked at. We know that cuff failure occurs within the first 3 to 6 months, which is in the early phase of our healing process. Dr. Galotz looked at knowing that tendons like loading, so that it facilitates healing. So we want to load these tendons. So earlier rehab may help this. However, we're trying to protect our tendon repair. So what's the best thing to do? So a lot of studies, randomized controlled trials, systematic reviews, meta-analysis looking at this, still some conflicting evidence supporting both strategies. Cheng et al. In AJSM 2015 did a meta-analysis. It showed improved range of motion with the early rehab, which is what we want to see. However, it trended towards an increased re-tear rate with the earlier group for the larger tears. And so the conclusion was more maybe we should be individualizing this postoperative protocol to improve healing. So small to medium tears, maybe a little bit earlier range of motion. Large tears, we delay the rehab. These reported healing rates that you're going to hear a lot about probably these next several talks. It's extremely variable. Even some studies, including Dr. Galotz's study in 2004, which is an MRI and ultrasound study showing only 6% rate of full healing. So only partial healing and a lot of full tears. It really is variable anywhere from 6% to 90%. So we know we're still trying to figure out how to get this tendon to heal. Our ultimate goal is to obtain tendon to bone healing with this meticulous technique, really being patient specific and tear specific. We know that patients functionally do better if their rotator cuff heals. There's studies on that. Functionally, they have better range of motion and strength. I say functionally because overall, all patients do well, even if it doesn't fully heal. But functionally, we do know we want the tendon to heal to give them the best outcome. The tendon to bone healing, a little biology, the healing begins with formation of this fibrovascular tissue between the tendon and bone and at the footprint site. Bone eventually grows into this interface tissue, and the collagen fibers then eventually lay down onto this. And so we're trying to, again, reproduce those 4 zones at the tendon-bone interface for an anatomic repair. There's 3 phases of the healing: an inflammatory phase, a fibroblastic phase, and a remodeling phase. And this is just a complex interaction of all types of growth factors in cells, way out of my league trying to discuss these things. But we do know that the tendon initially heals with a little more of what a scar tissue heals with, so primarily collagen 1 and 3, whereas normal tendon bone collagen is more collagen 2, 9, and 10. But so again, the biology and some of the augmentation we're doing is trying to make this tendon and bone interface look more like a normal tendon. Surgical techniques, again, I'm not going to discuss too much of this. Dr. Schlegel and the rest of the group is going to go through a lot of this with massive tears and repair techniques, but the ultimate goals are provide a high initial strength to reconstruct the anatomic footprint, and then obviously maintain this fixation throughout this entire healing period. We think this is at least 6 months out to 12 months and maybe longer. The technical considerations to include excursion of the rotator cuff tendon. I think Dr. Braden is going to discuss some slides and tendon transfers, and our main goal is not to over-tension this repair. There's a lot of discussion and information about the technique of single versus double row, which is just how we repair the tendon, and multiple rows of anchors versus 1 row, versus this kind of speed bridge, transosseous equivalent type techniques. And just a PubMed search, you can see, I mean, you literally can get information for days about that. And we know a lot. So a lot of evidence. We know that double row repair restores more of the anatomic footprint. We know that it is mechanically superior to single row techniques. There's several meta-analysis, level 1 and level 2 studies that show higher healing rates, double row repair. However, we still have not been able to prove a significant difference in clinical outcomes. And these are over the last decade, so maybe longer term studies will continue to let us know if this is the right way to do it. Dr. Gennario in our group, Dr. Bobick and Dr. Schlegel, looked at the cost effectiveness of double row repair. Unfortunately, it's not cost effective with rotator cuff, no matter what the size. However, you got to think about the re-tear rate and the long-term outcomes and possible need for future surgery, including a reverse shoulder replacement if they fail to heal or go on to rotator cuff arthropathy, or even a revision rotator cuff repair. It may make double row repair more cost effective if we look more at those factors. And so the technique, again, it is exhausting. There's a ton of things out there with technique, including the anchor fixation methods, type of sutures, knotless, anchors designs, including our all suture anchors that I like to use. We know just in general, the weak link is this suture tendon interface. It's the most common failure site biomechanically, excuse me, and then also what we see at the time of revision surgeries. A lot of factors can play into this: poor quality tissue, the vascularity, the patient factors, the surgeon factors. Do we do a good job, or were we meticulous with our repairs? And obviously mechanical over-tensioning and getting the excursion of the tendon. So that will lead us eventually down the road of we need to augment these repairs. What are we doing from a biology standpoint? What are we doing from soft tissue standpoint? Are we adding dermal allografts or synthetic grafts? What are we doing to make sure that we protect this weak link? And so in conclusion, we know patients all do well clinically after rotator cuff surgery, even with this larger re-tear rate that we're still seeing on larger tears. Is double row repair better? Biomechanically, we think so. Cost effective, we're still yet to determine. And again, failures are again occurring at the suture tendon interface. And I think we need to learn a lot about our biology to make sure that we're getting this perfect. And references, thank you. Look forward to the rest of the talks.